So in this case presentation, I was wondering what should I put for the cases, and I decided that we will take a look at these two cases. This is something that you're not going to find in the textbook, and I just want to highlight how important to evaluate the screening views to arrive to the correct diagnosis. I'm going to show you specifically the standard screening views, and we will read them together to see how we can make those diagnoses that you're probably going to see once in a lifetime. So the first patient was referred to us with the suspected fetal growth restriction in intracardiac echogenic focus noted in the left ventricle. She was prima gravida at 23 weeks gestation. And we performed the detailed fetal sonogram and fetal echocardiogram. We found that the fetus indeed growth restricted based on our definition. So the estimated fetal weight was 7th percentile in the abdominal circumference at the 6th. And then we saw the severe cardiomegaly. So here I would like to introduce to you this 4-chamber view. And using the checklist that we just discussed, this morning, I want us to take a look at this axial plane of the chest. So what can we see here? We can see that the heart is enlarged for sure. I mean, there is no way that you can fit even 2 hearts of this size to this chest, correct? I hope that you agree, and this is complete rib on each side, so we're in a very nice axial plane. But the enlargement of the heart demonstrates the very symmetric enlargement of all chambers. This is what usually happens, that we have the volume overload, and so that there is definitely something, happens to this heart, but we need to know what it is, so we're going to look further. So any other changes other than just a big heart? Anything else we can recognize here? Very good. Yes, so that there is a vessel on the right in the chest. This is a descending aorta, and this is a huge structure, seems pulsating, seems that it's vascular. So this is a typical place that where the azygos vein will be found. And even though we don't know what specifically this vessel is, but this is a really big azygos vein if this is azygos vein. Right, so it's even bigger than the aorta. Remember, it needs to be 3 times smaller. This is huge, okay? So maybe this is the source of the volume overload for that 4-chamber view. So the next view that we want to take a look at, this is our next screening view. This is the 3-vessel in trachea view. What we can see here? We can see here that the azygos indeed drains to the superior vena cava, and this is huge. Right? So if we will compare the size of the azygos vein to the size of the ductal arch or aortic arch in this view, this is just unbelievable. Well, we have the cardiomegaly, the still preserved cardiac function, but if it's preserved cardiac function or not, this is our upper abdominal level. So what do we see here? Ascites. Let's vote. Who thinks it's an ascites? Okay, who thinks that we probably need more information? How can we get the more information? Then something looks abnormal on 2D. The next step is to add color. And we did. What do you think now? Is it ascites? No. What is it? So we have the aorta, the IVC, the gallbladder, and the stomach. This baby is in a cephalic position, and we can see the abnormal course of the umbilical vein. So this is a very, very dilated umbilical vein that has extrahepatic course, and it drains to the azygos vein. How bizarre. So this is the case of the direct drainage of the umbilical vein to the azygos vein, the complete agenesis of the ductus venosus. Okay, so looking at the sagittal plane, this is bicaval view, and this is huge. This is the largest azygos vein I have ever seen in my entire career. So, and this dilated because we have that abnormal connection of the umbilical vein to the azygos vein. Okay, so here you can see the utilization of the 3D, and here we can clearly visualize the inferior vena cava, the descending abdominal aorta, and the azygos vein draining to the superior vena cava, so that the utilization of the 3D imaging helps the navigation through all that multiple vascular structures that you can see in the chest and in the abdomen. You may ask me what happened to the patient. The patient was going to relocate to Boston, so we contact Boston Group and Dr. Tveretsky, and they followed this patient by the rest of the pregnancy. Once the baby was delivered, they clipped the cord, and guess what? Nothing was to repair after that. So that within the next 6 months, the size of the heart just get back to the normal. And so the baby is now 3 years old, doing fine, never had a surgery, never had issues. So 2 important things to highlight in this case, that the color Doppler is important, that following the protocols is important, and basically it's very important to understand the physiology, and that sometimes the heart can be affected due to some extra cardiac problems. All right, so now we are, I think, ready for the next case. And this patient basically came to us to establish her prenatal care. She came at 8 weeks gestation for early pregnancy evaluation. So we did a dating and viability. We confirmed what we're supposed to, that the pregnancy is within the uterus, that there is the positive cardiac activity. We measured the crown rump length, and it was compatible to the gestational age based on her menstrual history. So we did good. We confirmed the dates. We found the pregnancy in the right location. But what was really concerning, that even though at that gestational age it's probably not the scope of the ultrasound imaging, but we identified the fluid collection extending from the fetal neck to the spine and the entire body. So kind of was suspected the early cystic hygroma. So, but we were very cautious to make this call at that point, and we brought her back in 3 weeks. So this is our early imaging at 8 weeks and 4 days, and you can see significant fluid collection pretty much along the entire fetal body. Okay, so now she is back at 11 weeks gestation. So we can see the persistence of that fluid collection. So at this point, we call it the cystic hygroma. We measured that at the level where the nuchal translucency is supposed to be measured, and it was huge. It was measured 10 to 9 millimeters. And surprisingly enough, at that point, we were not able to see any evidence of major fetal abnormalities. So this is how that baby looked at 11 weeks gestation. I think that you can appreciate how much the fluid collection did increase since the previous ultrasound, multiple septations, classic presentation of the cystic hygroma. So if you work at the MFM practice, what do you do next? Genetic counseling, and you will offer the invasive procedure. It was offered. She underwent CVS, and based on her CVS results, everything came back normal. How surprising, right? So we brought her back for early assessment and early fetal echocardiogram at 15 weeks gestation, and this is where we start seeing some changes. First of all, we were able to pick up the situs abnormalities because we were able to identify that the fetal stomach and the fetal heart are located on the right side. So, but we were not able to see any major malformations, which is surprising for situs abnormalities. This is very typical. We saw abnormal curvature of the spine, and again, the cystic hygroma got resolved. We saw some cystic pockets, like the lymphatic nodes on the neck. So, but our focus is on the heart, and here is the fetus in the breech presentation for us, and you can see that this is the left side if the baby is in the breech position. So this is the left side of the baby, this is the right side of the baby, and the stomach and the apex of the heart are pointing to the right side. So situs inversus, so situs ambiguous, hard to tell. So, but if you look very carefully at the area behind the left atrium, we can see the double barrel sign. So at that point, we were like, okay, so maybe baby has the interrupted IVC that needs the further evaluation. So she had the further evaluation at 18 weeks gestation, and again, we confirmed that this is abnormal situs. We suspected total anomalous pulmonary venous return, so that was really interesting exam. We tried to figure it out what's going on here. Alrighty, so this is again the fetus in a breech position. So this is the baby's left side. This is the right side. I just want to emphasize that without knowing that this baby is breech, you're probably never going to be able to pick it up situs. So that's why before you're looking at the baby's anatomy, always make sure you hold the probe correctly and that you determine the position of the baby within the uterus and the baby's laterality. Okay, pretty symmetric chambers in the heart. Aorta, dilated vessel next to it. Is it azygous vein? Very likely. This is a typical location. So it's not that dilated like in the previous case. So, but what can we see here? We cannot really see the normal drainage of the pulmonary veins, at least of all pulmonary veins here. You can speculate, looking at the 2D image, that it might be something here, but you can see the normal portal sinus, and what's really, really important, that we can see a normal image of IVC on this abdominal circumference. If you can see a normal image of IVC, so why the azygos is dilated? Okay, so we are looking at the 3 vessel and trachea view. This is another our screening plane. Does it look normal to you? Or anything is missing? This is a still image, right? The PA, the aorta. Normal or abnormal? Who thinks it's normal? If it's abnormal, why? Well, let's think about that. We probably need more information. Let's add color. Normal or abnormal? What's missing on this 3 vessel and trachea view? Okay. So we are looking at the sagittal plane. We cannot see SVC here. We were not able to see SVC on the 3 vessel and trachea view either. But we can see a very dilated vessel that brings the blood down to the IVC. And surprisingly enough, looking carefully, we were able to identify the pulmonary veins normally. Now let's back to the 3 vessel and trachea view. We cannot see IVC on either side of this chest. Can it be that baby has no SVC at all? Indeed, it's possible. And that was exactly the case with the bilateral agenesis of the superior vena cava. That the azygos vein draining everything, all the blood from the head and the upper extremities to the inferior vena cava. And this is how you can see that big vessel behind the heart that drains the, again, all the blood from the upper extremities and the head down. And once again, this is the normal IVC, normal aorta, and the dilated azygos that serves as the drainage. And I just want to highlight that the direction of the blood flow, if it's the interrupted IVC, is going to be the opposite, because the dilated azygos vein brings the blood up, and the direction of the blood flow in the aorta would be down. So here we have the direction the same, and that was very diagnostic. And then we saw some, we thought initially VSDs, but indeed they were coronary fistulas, also surprising. And you can see the dilated right coronary artery, that fistulas, and Most of the time then you see something like this, pay attention to the ductus arteriosus, because in this case we were able to find the constriction of the ductus arteriosus, and this is very, very typical to have the dilated coronaries and the persistent fistulas, especially if you have obstruction of the ductus arteriosus, which based on our understanding was unrelated to what we saw on the situation with the IVCs. So this is basically the final diagnosis. Cardiac anomaly that was consistent with the bilateral agenesis of the superior vena cava, that the venous return from the head and upper extremities via azygous and hemiazygous vein to the IVC, mild obstruction of the connection between the azygous and the IVC. Fortunately, baby didn't develop any superior vena cava syndrome after birth, but also the incidental finding in this case was the mild restriction of the ductus arteriosus, and we also saw the mild tricuspid and pulmonary regurgitation because of that. Thank you very much for your attention.